Good evening, all. So we will go into the uh, proper sessions now. So the first topic was ABG analysis. So as we all know, as most of them who have cleared have told that the time limit. Okay, so EDIC is just about time. Okay, so you need to think within the time, you need to frame an answer within the time, and you need to give the answer within that time frame. Okay, so it is, as sir told, a high voltage suddenly coming to you. Okay, so similarly, the thing is in ABG analysis, what is the most important thing is we need to sit, calculate it. Okay, so if it is a metabolic acidosis, I need to calculate 1, 2, 3, 4, 5, 6 steps. By then, I think most of your time is gone. So how to make your ABG analysis easy is the first thing. For that, you need to practice ABGs. So all of you all are working in the ICUs. Okay. So daily sit, take some random 5 ABGs. Okay. Try to solve them within, if you're taking 5 ABGs, try to solve them within 10 minutes. Then discuss that with your colleagues or your juniors or someone else and see whether your answer is right. Okay, so daily practice is required for you to answer within that 1 to 1.5 minute of your final exam. Second, what I benefited is, so if you have a colleague who is also giving your EDIC exam, so two people sit together, take the ABGs. So what we did is, I was a junior consultant at that time. So when I was giving my EDIC exam, I just had a senior consultant who was also giving the exam. So we were just, okay, one question, both were solving. We would keep a timer there. How many minutes we would complete a single ABG? So day one, it took 5 minutes. Day two, little less. So this is how you need to come and sit at least within 1 minute to 1.5 minutes. Okay. So this is the basic thing which I feel is the better way to approach to the ABG analysis. So today, for the next 20 to 25 minutes, I'm going to discuss some important ABGs where I give you a scenario and you try to solve it within 1 to 1.5 minutes. So before going to the actual thing, so I would not like to discuss everything in detail because ABG analysis only is a 1 hour class. Okay, so I'll directly go to the main steps that is required for your exam. Okay, if you see, so many slides are there before this short form of the complete ABG analysis. So, okay, so the first thing, as we all know, the first step is to assess whether, see the pH, see whether it is an acidosis or alkalosis. The second step, to see your primary abnormality of the acid-base balance, whether it is a respiratory or a metabolic primary component. Okay, suppose you have come to a thing that it is a respiratory, primary is a respiratory acidosis. Then you need to do two things. One is you need to see whether it is acute or chronic. Okay, so most of the clinical scenarios will tell you whether this patient, they give you a hint whether this is a acute or a chronic or acute on chronic. But in some situations where you will not be able to assess, yes, whether this is an acute or chronic, okay, please note down there are some formulas to actually get you an answer for that. Okay, so that formula is delta H plus divided by delta PaCO2. Okay, so delta H plus is the expected H plus, which can be got through your Henderson-Hasselbalch's equation, okay, or a table that is there. So for us, better to calculate is the Henderson-Hasselbalch equation, or the easiest way is take the pH. If it is 7.23, okay, the last two digits, that is 7.23, okay, take that, minus it from 80. 80 minus 23, what is the answer you get? That is your expected H plus. That has to be minused by 40. Okay, this is your delta H. This is divided by delta PaCO2. Okay, so delta PaCO2 is, if the patient's PaCO2 is 60, 60 minus the normal, that is 40. When you do that, the value you get, okay, If it is less than 0.3, then it indicates it's a chronic respiratory acidosis. If it is more than 0.8, then it is acute respiratory acidosis. If it is between 0.8 to 0.3 to 0.8, it is acute on chronic respiratory acidosis. Similarly, in case of respiratory alkalosis, you can use the same formula to know whether it is acute or chronic. Okay. So this is only when you're in doubt. Otherwise, most of the questions will have the hint of whether it is an acute or a chronic. The second is your compensation. So we all know the compensation formulas. Okay. So for metabolic acidosis and for respiratory acidosis and respiratory alkalosis, it is 1, 4, 2, 5. So I'm not going to discuss in detail because that is the basic compensation formulas that you should know. Okay, that is about the respiratory acidosis. For respiratory alkalosis, as I told, if you want to see whether it is acute or chronic, you can use the same formula and compensation as it is. Now coming to your metabolic components. Suppose if the primary component is your metabolic acidosis, okay, then you use your Winter's formula for the compensation. That is 1.5 into bicarb plus 8 plus or minus 2. Okay, so this you should keep in mind, and you should mentally, if it's better if you calculate it mentally, okay, rather than taking a paper pen. Okay, you can try when you practice that you are going to get that mental calculation. Okay, so after calculating your metabolic acidosis compensation, the next thing you should go is to see your anion gap. Okay, so after anion gap, don't stop it there. You should go to your next step to see if there is any associated or the mixed disorders involved in this metabolic acidosis, for which you're going to calculate your gap ratio. Okay, so what is gap ratio? It is delta anion gap by delta bicarbonate. Okay, for easy remembrance, if your delta gap is 1, it is pure, it is hagma. If it is less than 1, it is nagma. If it is more than 2, it is associated with metabolic, it is not acidosis, sorry, it is metabolic alkalosis. Metabolic acidosis plus metabolic alkalosis if your gap ratio is more than 2. Okay, so this is about your metabolic acidosis. If the primary is a metabolic alkalosis, okay, then you have a formula which is 0.7 into bicarb plus 21 plus or minus 2. Okay, so these formulas should be just kept in your mind. Okay, and the most important thing is when there is a mixed disorder. What is this mixed disorder? When do you get that doubt? Okay, if in your ABG your pH is normal, that is 7.4, but there is an abnormality in your PaCO2 and bicarb, then the first thing that you need to keep is, yes, this is a mixed disorder. Now, what is this mixed disorder? What is the primary? How to calculate the primary here? Whether it is respiratory or whether it is metabolic. Okay, for which there is one formula which I would like to show you once so that it's easy for you to remember. Okay, so this is known as bicarbonate percentage difference. Okay, so percentage difference is whenever there is an abnormality, you don't know whether the primary is a respiratory or whether the primary is a metabolic. Okay, suppose example you take. Okay, pH is 7.25. Yes, there is an acidosis. But what is the doubt here? Here bicarbonate is also low and your PaCO2 is also high. So which is actually the primary cause in this? Okay, to assess this, you have something known as the percentage difference. So what is that? You have to take two differences. One is your bicarbonate difference. So normal bicarbonate, what we take is 24 minus what was the bicarbonate in your ABG, 16, divided by the normal, 24. So what you got is 0.33. Now, second, you calculated your PaCO2 difference. Okay, 60 is the normal thing, that baseline thing which we take, minus here, sorry, 60 is the PaCO2 that is given in your ABG, minus 40 is the normal, divided by 40. So what you got is 0.5. Now, if you see in this both, which has a higher contributing factor for the pH abnormality, this is 50% contributing, whereas your bicarbonate difference is 33%. So here, your primary abnormality is the respiratory acidosis. Okay, so this formula is used only when you don't know which is your primary abnormality in the ABG. Okay, so hopefully I think you understood this. Now, this was the thing that I wanted to show you before going to the actual scenarios. Okay, so shall we start? Okay, some 8 to 10 ABGs are there. I will keep a timer of around 1 minute, and you have to solve this and put it in the chat box. Okay, and then we will discuss in just a few seconds about the answer. So you can start, go through this question, go through the scenario and the questions, and you can answer in the chat box. Okay. So see the compensation. I don't want just the primary one. If it is a respiratory acidosis, please do the compensation and then give the complete, whether it is an acute, chronic, everything. So your answer should be what the examiner is expecting. Okay, so take 1 minute time and give your complete answer for the acid-base status. Okay, respiratory acidosis with metabolic compensation. Okay, what type of respiratory acidosis is this? Is it an acute or a chronic? Yes, it is chronic. Yes, your history says that it is a daytime somnolence. Patient has a OSA component. So it is chronic respiratory acidosis with partial compensation. Okay. Now, Hemadri, what is this 230? Is that the A gradient which you calculated? Diagnosis is OSA. Okay. I think most of you all know the formula for A gradient. Okay. I will, if possible, I'll just show it once and an easy way to remember it. Okay. So this is a formula for A gradient. Okay. FiO2 into 760. So 760 is your atmospheric or the barometric pressure. 47 is your water vapor pressure minus your PaCO2 divided by your respiratory quotient, which is 0.8. So if in any question, if they tell the FiO2 is 0.21, okay, and please calculate the AA gradient, easy to remember is this value. Okay. So always remember 760 minus 47 would be 713. This is one of the value that you need to remember. And if they tell that the FiO2 is 0.21, so the entire value of this will be equal to some, it will come about 149.7 something. Keep it as 150. Okay. If they tell FiO2 is 0.21, so the entire value of this will become 150. So 150 minus, you have to just put your PaCO2 and calculate it. Okay. So for the easy calculation, usually it will be 0.21 the FiO2. So keep this, the entire thing as 150. And when you get this value, you have to minus the entire thing with your PaO2s in the ABG. Okay. So we will see your answers, whatever you told was correct or not. So it is chronic respiratory acidosis with metabolic alkalosis component. So your AA gradient, someone has written around 30, right? It's around 33. So one more thing which you need to know is when they ask you AA gradient, try to interpret whether it is normal or abnormal. So here calculate, and they've asked you interpret the AA gradient. So how to interpret your AA gradient? So for that, this is the best slide. Okay, otherwise I've actually put it in the, okay, so this is the best one. I'll just remove it. Okay, so always see your AA gradient. Suppose if your AA gradient is increased, okay, so just see whether you will be able to correct your AA gradient by providing supplemental oxygen. Okay, so if you're able to correct your AA gradient with supplemental oxygen, that is after you provide some oxygen, your AA gradient is decreasing or have become normal, okay, then it indicates that there is some VQ mismatch. And in the context which they give you the question, you should see what the patient has. Whether the patient is having an airway disease like asthma or COPD, whether the patient has some interstitial lung disease or any alveolar diseases. Suppose even with providing some additional oxygen, your A gradient is not correcting, then that indicates that there is a shunt. Okay. So this is how you need to even interpret your ABGs. Okay. So in this case, sorry, something has happened. Okay. So in this case, the A gradient is 33. If you tell, is it normal? What should be the normal A gradient? Anyone? It's between 10 to 50. And as the age increases, the A gradient also increases. Okay. So this is above the upper normal limit. Okay. Even for an elderly patient. Therefore, the hypoxia here is not purely due to hypoventilation, but there is an additional VQ mismatch or a shunt that is present. And as you people told, the diagnosis is OSA. Now coming to the next question. Okay. You can go through the question and give me the answer. So COPD admitted for elective cholecystectomy, FiO2 0.21, pH 7.55, PCO2 is 63, PO2 is 63, PCO2 56, your bicarb is 48, and your base excess is plus 22.7. So what is your ABG? Interpret and calculate your AA gradient and give 3 measures to improve this kind of acid-base disturbance. Okay, I got something in the chat box. It's metabolic alkalosis with respiratory compensation. Okay. With respiratory compensation. Okay. Your AA gradient, your FiO2 is 0.21 here. So the entire value 150 minus what is your PaCO2 here? It is around 56. So 56 divided by 0.8. So what will be your AA gradient? 80. 70. Okay. Okay. So let's see the answer. So as you were told, it is a primary metabolic alkalosis with some respiratory acidosis. Your AA gradient is 17. That's very good. I think you're not minusing it with your PaO2s. Who is this? Some MB. Okay. You got an 80 that has to be minused with your PaO2s. Then comes your 17 value. Okay. So, as you know, what is the question here? Why is this patient having the metabolic acidosis? He is a COPD patient. And he was actually planned for a elective cholecystectomy. Okay. So, this patient could have been on a long-term diuretics, okay, causing hypokalemia and leading to the present situation. So, correcting hypokalemia, ceasing your inciting agent such as diuretic or infusing saline, and possibly by administrating your parental acetazolamide. So, these are the three measures by which you can reduce his metabolic alkalosis in this particular case. Okay. Go to the next question. So they have given so many hints here. 22-year-old woman who is 33 weeks pregnant. She met with an RTA. She has a rib fractures for which she was receiving analgesia. Vitally, she's stable. Abdomen was non-tender. Now, they're given a barometric. Her FiO2 here is 0.5. pH acidotic. What was the cause of the acidosis? You need to calculate and let me know. Respiratory acidosis with metabolic acid. Okay. Okay. So is everyone okay with Mahesh Sinde telling it is a respiratory acidosis? The PCO2 is normal here. What is the PCO2? It is 42. It is normal. Metabolic acidosis, Mohammed. Yes, very good. Mahesh, pregnancy is a state of chronic respiratory alkalosis. And here, a PaCO2 of 42 for a pregnant lady. Is it normal or high? It is high. Okay. It is high. Patient has a rib fracture. Okay. She's not able to breathe. Okay. Already there should be an metabolic alkalosis. The normal PaCO2 in the pregnancy lady will be between 30 to 35. Okay. And here it is 42. So in this context, that is the reason that they have given pregnant lady with 33 weeks of gestation. So in that case, PCO2 of 42 is very high. So the primary automatically here becomes a respiratory acidosis. Okay, that is a very important thing that you need to remember. Yes, many of you all might tell it is metabolic. No, but it depends upon the scenario that is given here. Okay, so that is an important point I want to stress in this scenario. Otherwise, I think AA gradient to people will be able to calculate now. Already we have finished 2 questions about that. Okay, so we will go to the next ABG scenario. I am not able to. Okay. So the next one here, 18-year-old woman suffering from acute renal failure secondary to rhabdomyolysis is vitally unstable and she has been put on a CVVHD for past 8 days. Okay. Now here the pH is 7.45, PCO2 is 45, your bicarbonate is 31, sodium 135, potassium 3.2, chloride 94. The lactates are 5, albumin is 2.2. Now describe the acid-base status in this patient and I will ask you the next question later. Okay, you want to see for few seconds, then we'll go for the discussion. So after this, we'll just solve one more question for the uh, time delay that has happened. But you're going to have a feast of these different ABGs in the TRICS course in future. So I didn't get the answer for this. Acid-base balance status for this. Chloride responsive metabolic alkalosis with respiratory acidosis component. Okay, so everyone is okay with the metabolic alkalosis. Okay. Okay. Okay, let's see the answer. So metabolic alkalosis with respiratory acidosis. So when they interpret the ABG, you should also tell about the abnormal things that are present here. Okay. So hyperlactatemia with a normal anion gap, which everyone mentioned. Okay. So your lactates are very high here. But why is not your anion gap increased in this particular case? Lactates are 5. So ideally, hyperlactatemia should cause a high anion gap. Why is it not in this case? Very good. It is because of the low albumin. So you need to correct for the low albumin. Okay, that is very, very important. So how do you correct for low albumin? You need to add 2.5 to your anion gap for every 1 gram per dl of albumin below 4 gram. So here it is 2.2. Means you need to add around 5 to your anion gap. So when you add to your 5 to your normal anion gap, is your anion gap increased now? Yes, it will be automatically increased. So you need to even evaluate your albumin and then give your answer here. Okay. So you need to actually see each and every value that they give. So this question was put for the same reason. And I will just see whether this would be a better one or I want to give a better thing for you. Okay. I will give this one. Okay, this is the last question. So this is the BBG result from a man being treated for accelerated malignant hypertension. Okay, so it's a BBG. FiO2 0.21, his pH is 7, PO2s are still 75, PCO2 is 25, bicarb is 6, and your base excess is minus 24.7. So describe the abnormality, what is the likely mechanism, and what action should be taken. Okay, I'm getting many answers for this. So metabolic acidosis, metabolic and respiratory acidosis. Okay, what is a major abnormality that you're seeing? It is a BBG. Okay, a lot of values has been given. Metabolic. So what abnormality are you seeing in this case? So your abnormality that you're seeing in this case is severe metabolic acidosis. That's it. So if you're seeing your venous PO2 is elevated, okay, it is 75. It is like your ABG actually. Okay, your PO2 values here is like an ABG value of 75. So why this has happened? Because what is happening here? Patient is receiving treatment for accelerated malignant hypertension. So malignant hypertension. So what is the drug that you usually uses? Your sodium nitroprusside. So your sodium nitroprusside had caused a cyanide toxicity. Okay, which is causing your PO2s to be elevated in the venous sample. So how do you treat your sodium nitroprusside cyanide toxicity? Everyone knows how to treat it. Okay, so this is how they are going to give your ABGs. It won't be a very simple ABGs like what you daily solve. Okay, they will give you a hint. You need to catch that hint. Then only you'll be able to go to the further questions. Just simply describing an acid-base abnormality is not the thing that they are expecting in the edict type of questions. Okay, so why that has happened is the thing that is mainly stressed in these exams.